Well, hello, ladies and gentlemen, and this is me coming out of a temporary retirement. Um, I'm not really making any new videos at the moment, but what I do want to do is sort of go over some of these old videos I made, in particular some of these videos that somehow got lost in the YouTube system. A lot of my videos somehow lost sound, and I don't know why that happened. So I've been going through kind of trying to re-upload them. It happened that the asthma video I made was completely lost. So I am completely revamping this video. So hopefully you'll find this useful. This is just the general diagnosis and management of asthma. And it is newly updated. I think I originally made this video around 2014, so it's been about 5 years. Not a whole lot has changed though. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or in the I button on the upper right hand corner of the video. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, formulating differential diagnosis, treatment plan, things that'll be useful for you, especially as you gear up to study for step 3. A little bit goes a long way to help keep these videos free. All I'm looking for is like $1 a month. So thank you very much in advance for your consideration. So what are we going to go over? We're going to go over the bare essentials of asthma, what it is, the causes, how do you determine severity. That's going to be really important because that's going to dictate your treatment. The treatment of asthma is not very complicated. What you need to really know is where this patient is at as far as their severity, because that's going to dictate what medications you give them. Knowing a patient has asthma is very straightforward. It's a very straightforward diagnosis. You may want to eliminate some things that may be causing the asthma, but a patient who has asthma on a vignette, and even in real life, it's going to be pretty straightforward. The real problem comes, and more of an art form comes when you want to determine how you're going to treat the patient. And there is a chart that you can look at that shows how many times a week are they having nighttime symptoms, how many times a week are they having daytime symptoms, is it waking them up, are they going to the hospital, and you can determine where they're at on there. But you should be able to get the gist of how severe their asthma is based on a clinical vignette and in a clinical scenario too. But I will show you that chart. It really is not that difficult to memorize because it's a step-up approach. So we use one medication with very, very, very mild asthma, and then with each step as we move up, as it gets, if it's more and more severe, we just keep adding drugs on. So you'll always start out, for instance, with an albuterol, with that short-acting beta agonist. Everybody with asthma has that. And the more severe, they just get more stuff. And then we'll talk about the acute exacerbation. This is going to be management in the ED and inpatient. So some essentials of asthma. Asthma is acute or subacute inflammation of the airways, which can be precipitated by a variety of factors, resulting in bronchial hyperreactivity. So the bronchial smooth muscle is contracting and in way over reacting to whatever stimuli are there. So when you go outside, you don't have asthma and you're exposed to dirt and dust in the atmosphere and pollens and stuff, you may cough a little bit, but you're fine. If you have asthma and you go outside and all that, you may get an asthmatic attack, and that's just because your bronchi happen to be hyperreactive. The cause of this is idiopathic, but ultimately this is going to result in airflow obstruction, and this can be deadly. There are varying degrees of severity and chronicity. Mild attacks can linger for weeks with only just slight impairment. The patient may be coughing, dry cough. And then severe attacks can present as really deadly medical emergencies where the patient's basically choking. It affects 5 to 10% of all Americans, which is about 23.4 million people. And a preponderance happen to be in children. Boys tend to be more frequently affected than girls, but women are more affected than men. Don't know why. Blacks are more affected than whites. Don't really know why that is either. may have something to do with environmental exposure. Black children are more likely to be living in urban areas where there's smog and there's pollutants, whereas white children are more likely to live in the suburbs and rural areas where you may run into more dust and molds and allergens in that regard, but perhaps that doesn't trigger asthma to the same degree. There could be a genetic component too. Interestingly, asthma is more prevalent in industrialized societies, which lends credence to possibly the pollution factor. Treatment is focused on reducing overall airway inflammation and aborting acute inflammatory attacks with a rescue inhaler. That's albuterol, a short-acting beta agonist. And patient education is very important, especially if a certain stimulus is noted. And because these are children, and because they often are children, and because they have to take, you're not giving them a pill. Or an injection, you're giving them an inhaler, and they need to know how to use that inhaler. And so it's really useful to have an asthma educator around the clinic, or a nurse who's very good at teaching children how to use their inhaler. Or if you, as the provider, are able to teach a child, maybe you take an inhaler yourself. I do for exercise-induced asthma. You can teach the child as well. So it's good for everybody to know how to do this. One more thing I was going to talk about here. So when you have asthma in a child, it's much more problematic than an adult. And if you go back to my airway mechanics lecture, I talk about Poissier's law. And that has to do with the caliber of the airway. So if you already have a narrower airway to begin with, a 10% decrease in that airway is going to increase the resistance by a much greater degree than if you have a wide airway and you have a 10% decrease in the diameter of the airway. So you can go back and look at that. I presented to you mathematically. If you're, sort of physics inclined, you might enjoy that lecture. It's good to know, especially if you're taking step 1, because they like the physiology and stuff. Okay, so you have asthma. What are our cardinal symptoms of asthma? Shortness of breath, wheezing, increased respiratory rate, and then a history of allergy. And remember that this is an obstructive respiratory disease. If it's really bad, you may notice accessory muscle use, decreased breath sounds, and diaphoresis. This is where it becomes an emergency because this is respiratory distress. The number 1 cause is idiopathic, which you can't really call that a cause because it just means we don't know. Person's got asthma, we don't know why. Allergens, mites, animal, pet dander. Exercise can induce asthma. That would be for me. When I was in 7th grade, I had to run the mile for the first time in Phy Ed class, and I was wheezing the rest of the day. I was able to run the mile just fine, but the rest of the day I was wheezing. When I got taken into my primary doctor, and I think I was only like 12 years old, and they put me on a exercise machine, and they had me blow into a spirometer, and they gave me albuterol to take from then on out, and it never happened again. So I still have the albuterol, actually, not the original albuterol, but I still have albuterol for when I jog and run, because afterwards I do get that tightness. So exercise-induced asthma, very real thing, very common. You'll see it. Infections can worsen asthma just because of the inflammation, and that can make the smooth muscle a little bit more reactive. So things like rhinovirus or bacterial infections like pneumonia and sinusitis. Reflux disease, again, you have an irritant here, and anything that irritates can cause hyperreactivity. So reflux disease, if you have reflux, comes up the esophagus, a little bit of it goes down into the trachea, gets into the bronchioles, you can get hyperreactivity that way. And then aspirin. I don't know why, but aspirin can worsen asthma, so that's a good thing to know. Okay, it probably has something to do with the leukotrienes and all that stuff that asthma plays around with, but you don't need to know. You don't need to know the details about that. Okay, so this is how we determine the severity of asthma, and we look at how often are they having symptoms during the day, are they waking up at night, if they're getting a short-acting bronchodilator, which they should, how often are they using it? How much subjectively does it interfere with their daily life? And then more objectively, we can do pulmonary function tests and we can see where they're at. Remember, this is going to be an obstructive picture. And from that, you can plot them onto step 1, step 2, step 3, step 4. Now, this is not something you need to memorize for the test, but what I do want you to be aware of is that if they are having an abnormal pulmonary function test, then in between episodes, then you need to consider possibly moving all the way up to step 3 to step 5, possibly putting them on oral corticosteroids. However, most patients, when you initially diagnose them with asthma, it's going to be, you're just going to give them the albuterol. If they start waking up a lot at night, then you want to go more with the long-acting beta agonist in addition. And why is that? Well, because the short-acting beta agonist will abort an episode. But when you go to sleep at night, that's not very useful because you don't want to wake up at 2 in the morning, wake up at 5 in the morning having asthmatic episodes. You want something that's going to get you through the whole night, and that's why those long-acting beta agonists can be useful. So just use your common sense here. But this is a chart to help you kind of figure out where you should be. Now, this is the step-up approach. We'll come back to this in a little bit. I'm going to go over all of these drugs. I've abbreviated them here, starting all the way at step 1, which is the most mild form of asthma, with a short-acting beta agonist taken as needed. And then as we move up, we're going to start introducing corticosteroids. So we start with a low dose, and then we move on to a medium dose, and then to a higher dose. And typically when we have corticosteroids, inhaled corticosteroids, often we're going to add on a long-acting beta agonist, and we generally will combine those into one inhaler, so they're not using 2 different inhalers. And then there are some other medications that are used. These are more low yield for the test, but I will just cover them. If you're taking step 1, you may want to know the pharmacology of them. But if you're taking step 2 or 3, the only additional one that you really should be familiar with is omalizumab, which is slightly newer, but it's been around since the early part of the decade, I would say. So here are asthma medications. The big ones are the beta-2 agonists, both short-acting and long-acting, the inhaled corticosteroids, which vary by dose, and then other medications, including mast cell stabilizers, leukotriene receptor antagonizers. That would be like Montelukast or Singulair, theophylline, xyloton, ignore that E at the end, and omalizumab. Okay. So let's move on here. Okay, so how do beta agonists work? Well, remember that beta agonists just work on those beta receptors, and there is an entire cascade, biochemical cascade. If you're taking step 1, go look that up because you need to know that. I do a lecture I don't remember what category I put it in, but I do an entire lecture on alpha and beta agonists and antagonists, and I go into the molecular chemistry of how this all works, the cell biology, but I'm not going to go into that here. That's very important step 1 stuff. For step 2, what you need to know is that beta-2 agonists relax smooth muscle, and that's exactly what you want to do when you have somebody with smooth muscle hyperreactivity, i.e. asthma. Okay, so the result is relaxation. So we have the short-acting beta agonists. The big one is albuterol, and remember, everyone with asthma gets albuterol. Long-acting beta agonists include formoterol and salmeterol. All right. So remember that the short-acting is for, it's a rescue inhaler. It's for a current episode. The long-acting are used for control, almost like prophylaxis, to get people through the day to prevent an episode from happening, or get people through the night as well. Inhaled corticosteroids, as you know, steroids work much differently. They use receptors inside the cell, so not at the surface. And what they do is at the DNA level, they reduce production of inflammatory mediators, and that reduces inflammation. Remember that anytime you're using a steroid drug, it takes time because it has to diffuse into the cell and it has to get to the DNA and then it has to alter transcription and translation. That takes time. So corticosteroids are never used for emergency treatment whatsoever. Never, 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 never. Some example of corticosteroids include fluticasone, budesonide, triamcinolone, and mometasone. You just want to know the names of these and know they're corticosteroids. You don't need to know the differences between them. That's not important. We're not pharmacists. With inhaled corticosteroids, remember, that's between step 2 and step 5, and really step 6 as well. But the difference is, and you're using inhaled corticosteroids the whole time, as you move up those steps, as it gets more severe, you're going to be increasing the dose of the inhaled corticosteroids. Some other meds include mast cell stabilizers, which is cromolyn, leukotriene receptor agonists, which include montelukast and zafirlukast, theophylline, which is a methylxanthine derivative. It can be taken orally or IV. Here's the problem with theophylline. So how it works is it's a phosphodiesterase inhibitor. And if you remember back to your step 1, that has to do with that cyclic AMP and protein kinase A pathway, which ultimately relaxes bronchial smooth muscle. But it also is an adenosine receptor agonist. And where do we see adenosine receptors? Where do you give adenosine? Think back to your code blue. You use adenosine to speed up the heart. And so with adenosine, one of the big complications with it, and the reason we don't like to use it, with theophylline, the reason we don't like to use it or give it is because it has a serious adverse effect of tachycardia, and you can produce an arrhythmia. So we try to avoid theophylline. Xyloton, also known as Zyflo, is a leukotriene inhibitor. This is very rarely used. So the ones I would remember would probably be montelukast, because I do see this in practice from time to time. I don't prescribe it very often, but I do see patients that are on montelukast. It's also known as Singulair, and you'll see this in the commercials, so it's pretty commonly used. These other ones I don't see. I think I saw a kid on theophylline when I was in my medical school training, and that would have been now going on 10, 11 years ago. So all these other ones really not used. Cromolyn is used, but typically not for asthma. It's used for allergies in general. I have seen it, but not used particularly for asthma. But these are sort of adjunctive medications that you may add on. You may see them. Definitely lower yield for USMLE though. Okay, so again, here's your step up approach, going in also to some of those other drugs that we talked about. So when do you step up? You're going to step up if you've got persistent symptoms despite the medications that they're on. You want to check. Very first thing you want to do is check their adherence. Make sure if it's a kid that they're using their inhaler properly. Okay, what you want to do is you want to give the kid a dummy inhaler, and you're like, okay, show me how you use this inhaler, because some kids will not take a deep breath in. They'll, take the inhaler, shoot it, and they don't breathe in. It's like, well, now you're just gonna get your beta agonist and your inhaled corticosteroid in your mouth, and that's not useful. You need it in your lungs. And plus, a big problem with these inhaled corticosteroids is if you put it in your mouth, you run the risk of oral thrush. So you got to take this properly. Again, if you could see a picture of me, I could show you and demonstrate it. But I recommend going on YouTube and looking up instructional videos on how to use inhalers so that you can convey this to your patients. As far as stepping down, if it's possible, you can step down if the symptoms have been controlled for 3 months. But that's going to be a judgment call. Does the patient want to take the risk of having more episodes? Because that is a possibility. On the other hand, are they having side effects? So this is particularly if they're at level 6. Do you want a kid on oral corticosteroids every day? No way. If you can get them off oral corticosteroids, that would be a really, really good thing. So, you really want to think about trying to step down if they're at 6. But again, it's all about judgment call and patient's values and what they're comfortable with. Oh, and then this here, if they're using their short-acting beta agonists, they're using their albuterol more than 2 days a week for symptom relief, it typically means they're going to need to step up. Okay. One thing, though, that I do want to emphasize just for clinical practice, on the USMLE, you'll always be given the drug names, but just keep in mind that these long-acting beta agonists and the inhaled corticosteroids are typically given as one inhaler. So you'll hear drugs like Advair. That's one inhaler, but it's fluticasone and salmeterol. So you've got your long-acting beta agonist and your corticosteroid in opposite order. And then there's Symbicort, again, another one that you'll see advertised. That's budesonide and formoterol. So the long-acting beta agonists and the inhaled corticosteroids are typically combined into one medication. And then the other one I didn't bring up, but it is important. I do want you to know this, and it may come up on the test too, is omalizumab. Omalizumab is it's marketed as Xolair, and all it is a human IgG monoclonal antibody, and what it does is it binds to free IgE. Remember, IgE is an immunoglobulin that plays a big role in allergic reactions, and it activates mast cells. So if you can glom on to all those free IgEs, you'll have less activation, degranulation of mast cells, and that's going to reduce your chances of having an asthmatic attack. Oh, and then this here, if they're using their short-acting beta agonists, they're using their albuterol more than 2 days a week for symptom relief, it typically means they're going to need to step up. Okay? So again, I kind of just brought that original chart into a table here. You can screenshot this or whatever if you want. All right. So these are my shorthand asthma treatment hints. So remember that all asthma patients get short-acting beta agonists, that's albuterol. If a patient is having symptoms more than twice a week, then they need an inhaled corticosteroids, and the dose is based on the frequency of their symptoms. If a patient is having daytime symptoms every day, then they need a long-acting beta agonist, and I would also say if they're waking up with symptoms, you should probably consider giving them a long-acting beta agonist as well. Most patients who have asthma are usually in step 2 or step 3, occasionally step 4. Step 5 and 6 are pretty rare. Patients who have asthma that have known triggers, so exercise-induced, pet dander like cats, they're usually in step 1 therapy because you go to your friend's house and they happen to have a cat. Well, you got your albuterol right there, and then you say, look, can we come play at my house where we don't have cats? Or if it's exercise-induced, if they're going to gym class or they're going, they want to play for the football team or whatever, they've got their inhaler there, and that will usually get them through. So if they're known triggers, typically they're just in step 1 therapy. They don't need the long-acting beta agonists or the corticosteroids. So for emergency management of an acute attack, when does this become an emergency? It becomes an emergency if they're in respiratory distress. So things like using accessory muscles of respiration, intercostal retractions, perspiration, diminished breath sounds, respiratory fatigue. What you want to do first is rule out a couple things. Rule out a foreign body. That will typically be done by EMS before the patient gets to you. You can do that with your stethoscope. If you hear wheezing on one side but not on the other, that typically points to a foreign body. Stridor, mucus, if there's a visible foreign body, obviously, or if there's anything in the history, you got a 3-year-old who's got little toys or something like that, no history of asthma. Anaphylaxis, very, 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 very important. Often we'll have a history of anaphylaxis, but look for things like bug stings, peanut consumption, recent medications. This will, however, typically involve other symptoms that go along with the difficulty breathing. So swelling, flushing of the face, runny nose, low blood pressure, and then, like I said, look into the history. So provided that you've ruled out physical obstruction or anaphylactic reaction, then the best initial step is the short-acting beta agonist. That is the most important treatment for asthma, is the short-acting beta agonist, the albuterol. And this can either be given as an inhaler or as a nebulizer. If you got a patient who's really flailing around, they're freaking out because they can't breathe, a nebulizer is great because an inhaler takes some discipline to use. You want to monitor their saturation, and it should remain above 90. Remember, you're watching your airway, breathing, and circulation. Supplemental oxygen is absolutely mandatory. 100% oxygen is ideal. And then routine labs should be drawn, including ABGs, as soon as possible. In the early stages of an asthmatic attack, the patient is usually in a respiratory alkalosis. Over time, this does shift to an acidosis because of the decreased oxygenation. But initially, you start out with a respiratory alkalosis because of the increased respiratory rate. You're getting more CO2 out. So a beta agonist, but what if the patient has a heart disease like congestive heart failure? In that case, you need to use your judgment. So if the patient is having a minor attack and is relatively stable, an anticholinergic may be preferred, but remember that they take longer. So if the attack is severe, you need to go with the beta agonist. But if the patient's just having a minor attack, then you can use something like ipratropium or tiotropium. Just remember that it takes a little bit longer. So you kind of have to balance the two things out. It really is a judgment call. And then any patient who comes into the hospital with an asthmatic attack, who's had respiratory distress, who needed a beta agonist inhaler or nebulizer, should be admitted for overnight observation. And then one other thing, if the patient continues to decline despite the nebulizer, you can give an IV beta agonist, something like terbutaline. And rarely endotracheal intubation may be necessary, but make sure that if you've got a patient who's asthmatic and sitting in the ER, if you're not familiar with endotracheal intubation, which you should be, but if you're not, make sure you know somebody around the hospital who is and is going to be ready to come over. Make sure they're not on their lunch break or they're not leaving the building. Make sure you know somebody around who's there, because if you need to do intubation, you're not going to have much time. So I think they teach endotracheal intubation in pretty much every residency program now, so you should know how to do this, but make sure, if you're a nurse practitioner or PA, I'm not sure how those programs work, if they actually teach that or not. Even if they do, not everyone's really comfortable with it, so just make sure there's someone around there that's comfortable doing intubation. And intubation's really a team effort too. And that's all I've got for you. If you have any comments, you can write them below. Otherwise, I will see you next time.